I can say for sure that I'll be able, as well as I'm able, to look him in the eye and say, hey, I did what I could with what I was given. But chillism is just made to do this living.
Testing. Good morning, everyone. Could I ask everyone to take their seats and we'll get started in just a moment, please? Can we have some lights? Danny, can we have a bit more light, please? Yeah. We don't want to get too romantic too early. We're just starting. Hi, everyone. I'm Tom Noseworthy, and it's my privilege to be the moderator for this wonderful 2 days. Welcome. Special guests, ladies and gentlemen, particularly patients, patient advisors, caregivers, physicians, decision makers, healthcare administrators, researchers. We have a wonderful group of about 160 people here today to talk about a subject that matters to all of us, because every single person in this room is getting older. It's truer today than it was even yesterday. Every day we get older. And for some of us, the importance of that is not lost at all. And we think about it quite a lot. Remember the time when you never thought about it at all? You never thought about your health. You never thought about aging. You never thought about all those things that are the natural parts of our lives. So we're here in this wonderful place in Prince George, a northern part of BC, and talking about older adults. And I think I might start with maybe a caveat from the outset that we may use a lot of synonyms for the words older adults, and some might not ring well with you. And so I just want to perhaps make a go-forward apology now, because sometimes we use the term seniors. Sometimes we use the term elderly, older adults, retired people. There's a lot of language that we use, and it's not an age phenomenon. It starts magically on your birth date at age 65. There's a whole movement of people now that are most interested in pre-retirement years from 55 to 65, which we'll hear about. Boomers with zip, called Zoomers. But to be serious, we ought to remind ourselves that just not that long ago, it was just like July 2015, some exact time in July 2015 when Canada reached that sentinel point where there's more of us age 65 and older now than those that are 15 and younger. So what? So a lot would be, I think, my response. So we're assembled here today because we want to talk about older adults. We want to talk about older adults as they age healthy and help propagate that. Not all of us will have that good fortune, and some will fall ill for different reasons, and we want to be able to support then the care of older adults in elder-friendly ways. And then some, and there's about maybe 500,000 of us now in the country, will suffer from the kind of cognitive decline that we call dementia, which is very devastating to families and caregivers, not to mention the individual. And then what about the million of us right now that roughly that have frailty? With that number maybe doubling in like 10 years? What bothers me about this is this notion that we have an emergency now. I'm really pissed off with the term tsunami when it comes to talking about older adults and aging. We've been getting ready for this for 50 years in this country. And the question is, are we ready yet? And the answer is, of course we're not. But good things are happening. So that's why we're here. We're going to understand more by the time we leave about what frailty and dementia is all about, but more relevantly, what does it mean to us, maybe even as individuals, but what does it mean to us as a system? And then perhaps venture into early discussions about what we could do. How might we make a difference? So this is kind of why we're here, and we're not here by accident. I really have two hats on. I'm conflicted today because while I speak on behalf of the British Columbia Academic Health Science Network, I'm also a board member of the Canadian Frailty Network, and there are other board members here. Joyce Breslin is a board member of Canadian Frailty Network, and other people associated with Canadian Frailty Network and our staff. May I say on behalf of the Canadian Frailty Network that we want to make a difference in Canada. Frailty needs to get on the policy and the political agenda. People need to understand it, not fear it, not be repelled by it, not be put off by the language of frailty, but rather to say, here's a set of vulnerabilities that we could do something about, and we need to get ahead of the game. We need to pay attention to other places that have done it well. So I really appreciate the Canadian Frailty Network as our principal sponsor here today, and our scientific director, John Muscaderi, here with us. We have others that have made this program essential and come together in a very wonderful way. I certainly want to thank the Rural Coordinating Centre for BC and Northern Health have been very helpful, particularly in figuring out how we would piece together tomorrow. First Nations Health Authority have had input, and the University of Northern British Columbia, and then, of course, the Canadian Academy of Health Sciences, and we'll hear from the Academy earlier or later on this morning. For those that follow social media, there's your hashtag CFOA19. There is going to be some photography over the course of the day. If you really are not satisfied with that, please signal as such. But we want to capture this event. And as you perhaps know, this has been live streamed. So hopefully anybody has access to the correct media, or indeed any media through webcasting would be able to have access to this program. Valemount Community Television through Bell Telesatellite TV and Channel 653, I gather. So really appreciate that support, and we hope that others will be able to hear this, and we'll also capture this content. We will be capturing the content, by the way, because there's going to be note-taking taking place, and we want to have at the end of this a set of proceedings that give us an insight to what did we hear? What does it mean for us? And what might we do about it? So that's sort of the general three categories of intent, what we want to harvest from the interactions and get your input and hear your voice today. We're happy that the University of British Columbia has accorded continuous professional development points for this, and so main pro points 10.5 if you're a physician certainly can be claimed for this event as part of continuing medical education. So that's a lot of introductory comments, and you'll hear from us over today. I want to walk you through the program a little later so you can see how it telescopes and fits together properly, but let's pause first and recognize where we are, who we are, and think about the presence we have here today. And I'd like to call on Elder Darlene McIntosh from the Clay Dene Nation to join me, if she might. Clay means where the two rivers flow together, and Dene means the people. Darlene McIntosh is a culture advisor at the Aboriginal Resource Centre College of New Caledonia, and she'll lead the territorial acknowledgement, prayer, ceremonial opening of the conference today, and we'll see her later this evening and tomorrow as well. And thank you very much, Elder Darlene.
Good morning. Hadi. Oh, that's not loud enough. Hadi.
Aye.
Not loud enough. Hadi.
Aye.
That's better. For those of you who do not know any carrier words, you've learnt your first carrier word today. Hadi means hello. So remember that. And instead of saying hello to somebody today, say Hadi. See if they know what you're talking about. So this is a wonderful event. As the doctor said, we are all getting older. We don't think we are, but we are. And I heard an interesting comment on CBC that in Canada now, a few years ago, 6% of people over 65 worked. Now it's up to 13% that we have working elders in the community, which is wonderful. Keeps you young. So I'll get you all to stand, please. So at breakfast, I was discussing or had a conversation with a doctor who was at the last presentation last night at UMBC, and I always talk about breath, and he confirmed that that's one thing that we don't even think about is breath. As doctors, I mean, that's got to be an important thing for you to deal with when you're dealing with patients. So what I want you to do is take a nice deep cleansing breath throughout your whole body. Nice deep cleansing breath. And remember, first gift from Creator, air, breath. The day you were born, you took your first breath, and you never stopped breathing for 70 or 80 years. And what do you call that? You call it a miracle. And each and every one of you are a miracle here to be of service. And that's what you're doing today. You're being of service to your fellow patients, friends, whoever needs your help. So take that next deep breath all the way down into your feet. And as you breathe into your feet, feel your feet sink into the deep, rich soil of Mother Earth. And there you can smell the richness of her soil. You can feel it between your toes. And there she grounds you into today, into this very moment, being present here and now, not in yesterday and not in tomorrow. Here and now. Live for today and not for tomorrow. And not only does she sustain our life here on Mother Earth, she also gives you all the energy you need in order to function today. So we are grateful for that, and we give thanks for that. So when things start to get stressful for you, remember the gift. Breathe. Breathe into your body. We, the Clyde Tenay Nation, have been on our traditional lands over 9,000 years as supported by lithic evidence. The changes have taken place over thousands of years supports the enduring strength, courage, and fortitude of our peoples. Our governance through the Blatlats brought balance and harmony with our brothers and sisters of other First Nations people. Clyde Tenay's clans are Frog, Lasilu, Grouse, Utsut, Beaver, Sa, and Bear Sus. Through this system, we know who our family connections are. Through our oral history, the use of legends told of our travels, our hunting and fishing territories, our trading practices with all peoples. May remember and hold steadfast in what Creator's blessed us with, and that is our traditional territories. Our ancestors have always welcomed people to our territories. On behalf of Clyde Tenay's elders, our youth, community members, and chief and council, it is absolutely our honor to welcome each and every one of you to our traditional territories. All my relations must see. Thank you. Please be seated.
Elder Arlene, thank you very much. Well, one of the great privileges I have at the British Columbia Academic Health Science Network is I I have a great board and a super group of people to work with in our management team. Our board chair is Charles Jago. For those from Prince George, he doesn't need any introduction. He's Mr. PG. If you're not from Prince George, it'd be important for you to know that Charles has had a lot of impact throughout BC, and particularly in the north. Formerly the president of the University of Northern British Columbia, chair of the Health Authority, Northern Health Authority, and now is chair of our board, and he's on many other boards and has influence in public and the private sector, and has had a big impact over the course of his life. Interesting, you know, Charles's background is, get this, Spanish history. And that's how he developed his academic career, spent time at McMaster before coming to BC. And if you get a chance to have a chat with Charles, very interesting to hear the convoluted story indeed about how he did become an expert in this world on Spanish history. Let me welcome Charles to the podium to bring us a few messages. Welcome.
So as chair, I get to speak after the president, which means he has given me notes and then scooped just about everything I was going to say in his own comments. But his reflections on the various euphemistic expressions we have to describe aging reminded me of a time some 26 years ago. My wife and I were driving across the continent, driving through the U.S., came to a motel late one night, tired, and the person said, "You want a senior's discount?" I said, "No." He said, "How old are you?" I said, 50. He said, "You're qualified for a senior's input or a discount." I said, "No." How foolish. Now I take every discount I can get. Anyways, thank you for your introduction, Tom. I have had the privilege of being here as a resident of Prince George since 1995, and in the various capacities that Tom has outlined. I regard myself not as a citizen of Prince George, but as a citizen of Northern British Columbia. And in the various jobs I've had the privilege of visiting with just about every community here, First Nations as well as others, and getting to know people, getting to understand the challenges they face. And it's been a privilege to make headway on some of those things. So now here, on behalf of the BC Academic Health Science Network, I'm hoping that we can make progress again today. So we have worked with many partners. Tom again identified the partners to develop this program. We hope that it is of interest to you. The fact that you're here suggests that it is, and that when you leave tomorrow that you will be enriched in your understanding. We're holding the seminar to focus on older adults, their health and social care, with a focus on rural and remote parts of the province. And I think that's very important. We occupy a vast territory, a vast geography, and in small communities there's often many challenges in getting the services that we require as we age. So today, hopefully, will give us a better sense of the knowledge that is emerging in this field and inform our own lives and practices. And putting a northern lens on these issues, I think, is very gratifying to me that the conference is being held here and with that focus in mind. So I want to thank all of you who have traveled far and wide to come here. It's a chance to share our perspectives on the challenges of aging, and as you can see, I am getting very challenged in that regard, so I'm hoping to learn a great deal from you. about the BC AHSN. It's an organization that was founded in 2016 with the intent of making a difference in getting research into practice and closing that gap between research and clinical practice. And we have had a very strong beginning in shaping the organization, but we still have a long way to go to reach our aspirations. BC has many strengths in the healthcare field. As I've always said, from my experience as being chair of Northern Health, innovation is not the issue. It's scaling up innovation to create system-wide change, because there's a lot of people, a lot of innovative people, a lot of knowledgeable people, and bringing their expertise and their sensibilities to the issues we face, and the chance to get together and share those understandings, I think, is what we're about today. The AHSN has just produced a strategic plan. It's on our website, so you're welcome to look at it. Again, it's very ambitious, but we're founded to be ambitious and to take healthcare reform to a higher level. So I welcome you all here. Please enjoy the City of Prince George. Please participate fully in the conference. And if you're too silent, Tom will speak for you, I'm sure. Thank you.
Thanks, Charles. I thought it might be useful to walk us through the program and some of the thinking behind it, and it might help you better understand our intentions. Of course, one of the things we want to do is start with healthy aging, for sure, because we want to try to retain and maintain that, but we will have a very in-depth discussion about frailty and dementia. And this is really an opportunity for, let me use the term, Southern expertise to meet Northern knowledge and expertise. With the great help of my colleague Ray Markham from the Rural Coordinating Centre for BC, we've been attempting to put this program together in such a way that we just don't talk at you and just provide unidirectional presentations. We need to hear your voice, your counsel, your insight. You will develop, I think, perhaps greater understanding of these topics by participating in that, but what's important is that you have expertise we need to hear from, particularly patients and family caregivers, the people that deal with the consequences when older, aging adults are not doing well. So we will want to capture all of that for sure. So to go through the program, we're going to start with the Canadian Frailty Network. So the Canadian Frailty Network has been at work now for several years and has lots to say, so I won't dive into it, as keen as I am necessarily to do so. And then right after that, we're going to hear from the Canadian Academy of Health Sciences that have done an in-depth study on dementia. So after those two opening, I think, rather important trend-setting conversations about what we know and our knowledge, that's when we have an opportunity to try to start making sense of that afterwards. So there will be a roundtable discussion that will work out a clearer understanding from individual tables, some of your thoughts about what you heard in the early instance. In the afternoon, Canadian Frailty Network has sponsored a huge amount of research over the last 6 or 7 years, and we're going to hear from some of the exemplars. And with the help of the CFN staff, Perry Kim, John, and others, we have very interesting 4 brief chats this afternoon from investigators that have something to say to older adults, particularly in rural, remote circumstances. And those are in the program and carefully selected, after which we'll have a brief discussion to make sense of what we heard from them. Tonight, everyone is invited to dinner. You'll be happy to know you don't have to tolerate any speeches. You don't have to get dressed up, but you need to come so you can have dinner, a little fellowship, chat about the day or whatever else you want to do. We'll have some light music on the side, but nothing formal, and that's this evening. Tomorrow morning, there's a couple of invitational activities early in the morning, but we get started a little later as a consequence. And Isabel McKenzie is with us. Some of you know Isabel as the British Columbia's Seniors Advocate, a rather unique position that BC has. It's true in, I think, one other province. So Isabel is, in my view, a very important person in older adult agenda in this province, has the power and the sanction to collect data and to have information and an evidence base upon which we can discuss how things are going in this province. And Isabel will talk about what actually is the reality in the province right now, and we'll see some interesting information that's quite BC focused and perhaps a prompt to where there are some opportunities for improvement. Then after the break tomorrow, we're going to have 4 workshops, and people are now moving into each of those 4 workshops into planning. For those of you that are involved with the workshops as the leads, we'll have a little scrum later on this afternoon, put on the finishing touches. If I might ask you to do that, we'll follow up with you. But those 4 streams now is a real opportunity for the audience to really make sense of the 4 topic areas that we've talked about. And in this one, we want to, again, continue down the road of the healthy aging component for one of those workshops. The second one is the Avoid program, which you'll hear about repeatedly now over the course of today, and we'll have a much deeper dive and get your impressions on that. Then a broader conversation about risk, and this one emerges in association with all of these subjects, but there's some distinct features that we have in older adults about risk. Who decides when, where, and how a person lives, where they live, what supports they get, what risks they're prepared to take? I'm sure the physicians in the room and the few geriatricians that are here know full well that, you know, you're worried every time you see one of those patients, are they going to burn down the shack, or is someone going to clean out the bank account? And so when you have those kinds of serious risks, that's kind of like different than falls and nutrition and the things that are in the Avoid program, but I hear a voice in the north that says we need to better understand risk. What is it? Do people accept risks? How do we make them aware of the risks? And to the extent that there's risks in any of this, can we reduce those risks and ameliorate them in any way? This is a topic of major interest in Northern Health, and that'll get pursued then again in the workshop in the afternoon. And then Isabel will Mackenzie will have the 4th workshop tomorrow to perhaps go a little deeper on some of the things that you would have heard in the data from BC, her views, and some of the recent, no doubt, case examples that you heard in the news and so on will all be potentially open for discussion there. And then to get us away at a reasonable time tomorrow, because I know there's people who want to get flights by mid-afternoon, we'll end on time. I promise we're going to stay on time. I have a big hook. And don't plan to use it, but everybody knows I have the hook nonetheless. But we'll end on time. But before we do, the real essence, hopefully, and capturing of the content that we've heard of those 2 days, we have a very carefully selected panel of northern experts that will reflect on what they've heard and what sense we can make of it. As I mentioned earlier, during the course of the day, you'll see some writing and so on going on. One of my colleagues, Karen Palmer, who's just right there, is taking charge of putting together and pulling together proceedings for us. And I don't want to inhibit your conversations that you have today in the least, but if we could massage them into the 3 or 4 categories, what were the main points we heard? What does it mean to us here in translation? What could we think that we might be doing about these things? If we can get the entirety of our 2 days moving in that direction, I think you can see what would flow out of that would be a very interesting set of proceedings that might act as information, at least, and some guidance to Northern Health, to RCCBC, to any one of a number of stakeholders, and the Canadian Frailty Network. So let me move to the Canadian Frailty Network as I introduce our scientific director. Canadian Frailty Network is one of the national centers of excellence. John will tell us about the background and so on and so forth. We're very proud of it. Interestingly enough, you know, it came out of a funny place. Canadian Frailty Network arose out of 3 different groups, but one of them was the Canadian Critical Care Trials Group. The Canadian Critical Care Trials Group, but John and I are members of that. In fact, we helped start it almost 30 years ago. The Trials Group is one of the most successful intensive care research phenomenon in the world. The Canadian Critical Care Trials Group has raised the bar in the quality of intensive care in this country, and they were some of the originators that led to the Canadian Frailty Network, because people like John on a regular basis, 1/3 of our patients are over age 65, sometimes in some units up to a half. Some of them arrive in, may I say, bad shape. And what do you do when a person with multi-system organ failure is 85 years of age and has no advance directives, and suddenly you're there needing to deal with what should have been dealt with over a course of years? So it's no surprise to me that the intensive care units and the ICU physicians in this country were part of the motivation behind forming eventually a Canadian Frailty Network. Let me introduce the scientific director. John Muscadere is still a practicing critical care physician. Does medical, surgical, intensive care. He's done it for decades. He can do it in his sleep. If you get sick, he's the man. And John is in Kingston. He's a professor in Kingston. And he has been an absolutely delightful person to work with as our scientific director. Please welcome John Muscadere.
So thank you, Tom, for that gracious introduction, and it really is a pleasure to be here. And I'd like to thank the British Columbia Health Science Network for inviting CFN to participate in this event and to help formulate it. So without further ado, I'm just going to start on my talk. Just want to set my timer here so I don't get the hook, the dreaded hook from Tom. I'm just going to, that's the slides, great. And, here we go. So, thank you. So I'm going to start off with disclosure. So I am the scientific director for the Canadian Frailty Network. We're funded by the Government of Canada through the networks of centers of excellence. And just for full disclosure, we do partner with non-governmental organizations, governments, and industry. And I also, in my ICU research, had to conduct some sponsored clinical trials. But none of what I'm going to be discussing has been influenced by our funders, and I'm not going to mention any industry in my discussion. So what I want to discuss today is I'm going to start with just a bit of an overview of aging in Canada, then go into frailty, then address the biggest question is why we should care about frailty, and then finally go on to discuss some tailoring care based on frailty assessments. And I want to give some example of frailty care innovations, some that we are spreading in Canada and some that are external to Canada, just to highlight things that we could potentially do to improve care for people living with frailty. So just a bit about the Canadian Frailty Network as a start. So we're a non-for-profit pan-Canadian network. We were originally funded in 2012. As I said before, we're funded by the federal government. So importantly, we're a multidisciplinary network. We include investigators, researchers, stakeholders, trainees, citizens, and caregivers in our network. We recognize that to address frailty in Canada, it's not just a healthcare issue. It's not a social care issue. We need to be broad and inclusive such that we can actually develop the innovations necessary to actually address this increasing demographic change in our society that Tom alluded to. And we aim to improve the care for older adults living with frailty and support their family and caregivers through practice and policy change. So we want to implement best practice, best evidence into practice, and hopefully influence policy at the end of the day. And this is our conceptual network. So when we started the network, we quickly recognized that there were two things when we started to discuss frailty. First of all is that frailty was under-recognized in healthcare, and we wanted to increase or enable the systematic assessment of frailty within the Canadian healthcare system. But the other aspect of it is also important, is that when we started to look at the evidence necessary to improve care, we saw that there wasn't very much evidence. So we've had two twin streams in our network. One is to increase the amount of evidence available to clinicians, to healthcare decision makers, to social planners, but the other, and along with the twin aspect of increasing the recognition of frailty. And once you start to recognize frailty, then you can actually measure what you're dealing with. You can actually measure quality improvement. You can actually see whether you're getting best practice. And ultimately, we want to have improved patient-centered care for older Canadians living with frailty. And an important component of our network is also we train the next generation of highly qualified personnel through a fellowship program, through funding of summer students. So I'm going to just start with aging in Canada. We know that the number and proportions of seniors over the age of 65 are increasing rapidly. At present time, it's around 7 million, which is around 16 to 17%. If you go to some other provinces, it's some provinces, especially the East Coast, it's much more. It's going to rise to around 10 million within the next 10 years. And the oldest, and when you start to look at that demographic, the oldest segments of the population are the ones that are growing the most rapidly. So the number of people over the age of 80, the number of people over the age of 90, and they're the people that are going to be most affected by frailty. And then if we start to look at from a societal point of view, the number of working adults for every senior is rapidly dropping. So actually how we go forward and reorganize our society, we need to take that into account. When you start to look at the volume of health services by age, no surprise it increases as you get older. It steadily increases with the highest utilization in the people at the highest stage groups, which are the people, which are the segments of the population that is growing the fastest. And then if you start to look at the healthcare consumption, so Canadians over the age of 65, when this slide was formulated, are about 16% of the population, but about 46% of healthcare spending is focused on that. And if you look at acute care, which is around 40% of the total of the $230 billion that are spent on healthcare, the vast majority of people in acute care beds are over the age of 65, and the vast majority of those are frail. Now let's look at what's happened with aging, or the evolution of aging over time. So looking at this curve, what it plots is function on the y-axis and age on the x-axis. So the first curve in blue, and I'm just going to use the laser there, So that's what it used to be like 50 years ago, or 50, 100 years ago, where basically you would maintain function, you wouldn't reach a certain point, you would rapidly decline and pass on. And interestingly, when you look at the age of retirement, it was set at 65 because that was the life expectancy of people around that time, and the government or the people who brought in retirement age felt that they wouldn't have to support you much longer because that was the age of the life expectancy. But what's happened over the years through public health initiatives and better health care, better societal care, immunizations, is that we've actually moved the curve over. So people are surviving much longer in good health and actually are able to lead very productive lives in spite of increasing aging, which was not present in the past. But then the other aspect of it is also true. What we've also done is extended the tail end of that curve, or the tail end of the curve where people are surviving longer with reduced function, with lots of medical conditions, poor quality of life, and that's been an area that's been neglected either in healthcare research. It's been neglected from multiple aspects, and that's frailty, and that's what we want to address. Now, if you actually start to think about what the future could look like, and this I always find this interesting. So all the evidence would tell us that there's a maximum human lifespan. We probably can't extend that. So what does the future look like? So what we want to do is actually change that second curve to the dotted line. We want to actually improve the curve so that you can survive and maintain function up until your maximum theoretical lifespan. And the saying that we found on a trip to Denmark, or it's older than they appropriate from somewhere else, was that we want to add life to years, not years to life. So we want, and that's the biggest challenge that's the biggest challenge to society. The biggest challenge to medical research is to change that curve, and that's what we increasingly need to focus on. So just saying that, I'm just going to go on to define frailty. I'm going to give you the medical definition for it, and I apologize for reading from the slide, but frailty is defined as a state of increased vulnerability resulting from reduced reserve and loss of function across multiple systems, reducing the ability to cope with normal or minor stressors. So the hallmark of frailty is that it pertains to increased risk for your stated age. And the increased risk is for bad things happening to you, either for suffering from adverse events, from being institutionalized, or dying. And what can happen when you're frail because of that increased risk is that minor stressors, so for example, influenza or a urinary tract infection or something which somebody when we're fit may not cause any problems, but what it does is in people who are frail, it can make major or catastrophic changes in their health. And frailty is associated with increased risk of physical, cognitive, and functional decline, adverse health outcomes, and mortality. So see, these are some of the common features of frailty. It's not exhaustive, but they're the most common ones. So the people who are frail will complain of unintentional weight loss. They'll complain of fatigue, low energy, and exhaustion. Their strength will be less. So the things that they could do before, carrying groceries, going upstairs, will be reduced. They'll have slow walking speed. They'll just not as fast or as able as they were before. And importantly, that starts to manifest itself as in loss of function and their ability to do things to get you around in your daily life. And frailty, as I said, have functional loss, may require caregivers at a higher risk for institutionalization and are frequent users of healthcare services. If we look at the vast majority of people who are frail reside in communities, and I'll talk about that in a little while, but the vast majority of long-term residents are frail. The majority of elderly patients who are hospitalized are frail. And importantly, when frail patients are hospitalized and have medical interventions, they have much worse outcomes than somebody of the same age who is not frail. And the determinants of frailty include a lot of public health aspects: social isolation, loneliness, inadequate nutrition, not being vaccinated, inactivity, polypharmacy, being on too many medications, and poor organization of communities, which can enable some of the determinants of frailty. So let's look at how common frailty is in Canada. So there's two graphs on this slide. The first one looks at frailty across age groups, and that's on this side. So you can actually have frailty even in younger age groups, but it tends to increase as you get older, and there's different ways of measuring frailty. So depending on which way you measure it, it can be around 20% with this one called the Fried phenotype. It's a bit smaller in people above the age of 65. But the important message on that graph is that frailty can occur at any age, although it's much less likely at younger ages. Then if we look at frailty in people who are over the age of 65, about a quarter of the people over the age of 65 are frail, and it rises increasingly. So if you're above the age of 85, about 50% of those people will be frail. So as I said, that translates into about 1.5 million Canadians, and by the end of the next decade, that's going to rise to over 2 million people. Gone over that one. So let's look at some of the specific groups and how common frailty. We know that frailty, the prevalence of frailty or how often it occurs is higher in women. We know that the poorer you are or the less socioeconomically advantaged you are, the higher the risk of frailty, and as shown by this study here, which looked at economically deprived neighborhoods and socioeconomic status, and both predicted higher incidence of frailty, leading to the previous, adding to the previous comments that there's a social determinants really impact the development and the prevalence of frailty. Frailty is more common in First Nations peoples. And what tends to happen is on this slide, so I'll just take you this slide, and I apologize, I'm just going to use the screen to the left to point out the aspects of it. So this is in general Canadian population. So if you look at frailty in the various age groups, 65 to 74, 75 to 84, and over the age of 85, when you go above the age of 85, the incidence of frailty is around 50%. In First Nations peoples, the incidence of frailty is around 50% in those over the age of 65, as opposed to 20% in the general population. And there's multiple reasons for that, including increased incidence of chronic medical conditions and likely some of the social determinants of health. So I've tried to paint a picture that Canadian population is growing older, that frailty is common, frailty is increasing, and frailty are the most vulnerable or the people at the highest risk of the aging Canadian population. So what I want to do now is just go over some of the specifics, how we can actually measure frailty. So frailty there's about 60 frailty assessment instruments that have been described. And unfortunately, that's led to the field, a bit of nihilism in the field that there's so many instruments, which ones should we use? But when you start to look at the literature, the reliability and validity for many of the instruments described have been poorly studied. There's variable agreement between scales and they have variable data collection burden. But what's happening as time has gone along is that some instruments have been much more studied, have been used and are being used much more commonly. And the three that I'm going to describe that are used probably the most commonly, the best studied, have the best evidence behind them, are the frailty phenotype model, the deficit accumulation model, or the frailty index, which was developed by Ken Rockwood at Dalhousie, and the clinical frailty scale, also developed by Ken at Dalhousie. So the frailty index, basically, it takes the view that, that frailty is a result of deficits that you accumulate as you age. As you age, you develop different things that are wrong with you. The more things that are wrong with you, or the more chronic conditions or health deficits you have, the higher risk of frailty. And basically what you do to look at a frailty index, you look at a certain number of conditions, and you can look if 30, 40, or 50 of those conditions are present, and then you, of the conditions that you're studying, you look at the number that are present, you divide the two, and you get a frailty index. And this has been referred as the Jenga model of frailty. I don't know if any of you have played Jenga in the past. So basically, that's those wooden blocks that you get, and normally the tower is fairly sturdy, but each block you take out is like a deficit, and the tower becomes weaker and weaker the more deficits you, the more blocks you came on, and finally it collapses. And that's analogous to humans, is that we can only tolerate a certain number of things wrong with us. And actually, if you study it on a population basis, basically, when you get up to about 70% of all the deficits present of the ones that you measured, most people do not survive that. And if you look at people as they age in population studies, they'll have more deficits. And importantly, if you measure frailty that way, it's been highly associated with worsened outcomes, hospitalization, or mortality in a gradient basis. So people that are less frail do much better. People that are more frail, based on that scale, do much worse, looking at all those specifics. The frailty phenotype is another way of looking at frailty, and this looks at frailty as a phenotype, or what you can describe, not as deficits. And they are overlapping, but the frailty phenotype has 5 specific criteria. One is weight loss or loss of muscle mass, and that's defined as less than 10 pounds, greater than 10 pounds of weight loss per year. Weakness, and you can quantitate weakness by doing a hand grip strength. Slowness, as I said before, people are frail, will slow down, and you can look at a walking time, low activity level, and exhaustion. And if you have any 3 of those criteria, you're felt to be frail, and at risk of developing full frailty is when those 2 of those criteria are present. Again, this is another validated, well-studied scale, and it correlates really well with long-term outcomes. The other aspect on this slide is the correlation between frailty and disability or comorbidities. Comorbidity, disability, and frailty can overlap, but they can also be they can also be distinct. In other words, you can have comorbidities or medical conditions and still not be frail. So the typical is the 80-year-old that may have diabetes, may have hypertension, but is still quite active and has no manifestations of frailty. On the other hand, the more of those medical conditions that you do have, the higher the risk of you becoming frail. And finally, the other scale I want to discuss is a clinical frailty scale. This is a 9-point scale. It was originally described to be used in conjunction with what's called a comprehensive geriatric assessment, but more information recently has shown that you can use it independently. It's valid, it's easy to use, it takes a couple of minutes to do, and in critical care we are increasingly using this as a way to quantitate people's function before they were admitted to ICU. It's a 9-point scale, with 9 being where you're terminally ill. That's the end stage of frailty, versus 1 where you're very fit, you have no limitations in the activity. 5 is where you're felt to be frail. 4 is that intermediate score. Again, very well studied. It's been reported in a lot of literature, and I will show you some evidence for that in a little while, but it also correlates with outcomes. There's other ways that we can also screen for frailty, and they're listed on this slide. So I said before that weakness is one way to actually, that correlates with frailty, and hand grip strength. So how strong your hand grips, and there's ways of measuring this quite readily. It correlates with frailty, and it correlates with long-term mortality. It also correlates with how well you're going to do if you're going to have an operative procedure. And as I said before, it's easy to measure and it's reproducible. The other one that's recommended in British Columbia is the 4-meter gait speed, which looks at a gait speed the amount of time that it takes you to walk walk 4 meters. So if you take longer than 5 seconds to walk the 4 meters, that suggests an increased risk of frailty, and you should have more detailed assessment. Lastly, the other one that is used commonly is the time to get up from a chair, walk 3 meters and back. And again, this also correlates with frailty outcomes and falls. Again, this is reliable and valid. All these are screening things that you can look for frailty. They are things that should, if they're done, you need more detailed assessment to go on from those. So how do we actually improve care? Just check how much time I have here. I'm good. So how do we actually improve care? Well, the major aspect is that we need to change our paradigm. We need to go from a disease-centered paradigm where we treat individual diseases, where if you have some kidney dysfunction, you go to the nephrologist. You have some heart problems, you go to the cardiologist. Some lung problems, you go to the respirologist. And not to denigrate each individual specialty. I'm a respirologist by trade, so, but I think sometimes that you get a mindset that you only look at the one specific element. And what we need to change is to a patient-centered, function-centered paradigm where we consider the whole person holistically, to look at the different things and incorporate, make sure that function is maximized, that it incorporates people's values into into what our treatments are. And the other aspect of it, if we really want to think about how we're actually going to improve care for frailty, frailty is not solely a healthcare issue. And that is really, really important. Better care for seniors living with frailty will only come through improvements in both health and social care. You cannot change one and not change the other. You need to change both if we're actually going to improve care going forward. And this is probably the hardest issue. It's probably easier to change one aspect of healthcare. It's much harder if you actually want to change healthcare and social care at the same time, because that involves a much bigger effort, much bigger organization, much more discussions, and that's why at CFN our network is multidisciplinary, and that needs to increase as we go forward. So, saying that, in that context, how can we address frailty? So there's 2 ways that we can actually think about. The first is to look at primary and secondary prevention. And the message here is that although frailty increases in how often it happens as you get older, it's not an inevitable part of aging. And primary prevention is preventing frailty from ever becoming present or from developing functional loss. Secondary prevention is that if it is there, mitigating its progression so that it doesn't progress. And that's under the concept of healthy aging, and I'll discuss a bit about what we're going to be doing at CFN in that regard. And the other aspect of it is that once frailty is present, then you need to tailor care to the degree of frailty. And the important message here is that it's not sufficient to identify frailty unless you're able to tailor care to its determinants, to its modifiable factors, to its causes. So you need to measure it and you need to actually address it. It's not sufficient to measure it, and any determination of frailty needs to lead to more detailed assessment. So the primary prevention. So how can we actually prevent frailty or mitigate its progression? And this is a public health campaign that we are in the process of launching. We've done sessions across the country, and this is we're going to be taking a public health approach, and we call it Avoid Frailty. And the reason we call it Avoid Frailty is that it's so nice that the things that you can actually do that have evidence behind them are fit into the nice acronym of AVOID. So AVOID stands for activity, maintenance of exercise, maintenance of avoiding sedentary activity, making sure you get the right type of exercise. Vaccination. Vaccination is incredibly important as we get older. Our immune systems don't work, and a bout of influenza can take somebody who is functioning well, who is fit, and put them in the hospital and make them unable to and they may be unable to recover to their pre-morbid health status. We want to optimize medications. We want to make sure that the medications that you are on are appropriate for the stage of life that you are in. We want to reduce social isolation. We know that social isolation is a determinant of frailty, and any aspects to reduce it are important. And finally, we want to optimize diet and nutrition. And as Tom said, you'll be hearing more about this in some of the other sessions and the specifics, so I won't spend a lot of time. So I'm just going to move on from this. So let's talk about some of the tailored aspects of frailty and how we can actually tailor it and try to improve outcomes. So I'll start with some of the initiatives in primary care. So we know that primary care or family physicians provide about half of all seniors' medical services, and we know that a high percentage of those are provided to people with that are older Canadians, and a lot of those older Canadians will be the ones living with frailty. So any improvements in care has to be delivered at the primary care level. And this is the result, and what we're actually doing in this regard is implementing practice changes in primary care in practices across Canada. So this was the result of a call for innovations that we put out at CFN for looking at. The call was to submit to us innovations in advancing frailty care. We were overwhelmed with the number of innovations that are happening across Canada. We received 79 innovations of people that were doing innovative things in different areas. So what we did is, because as the previous comment is, we are innovative, but we lack the ability to scale and spread. So what we took is we took the 5 highest rated innovations that was judged by a panel of experts. They had a lot of commonalities. They were all focused in primary care, and we had the resources, and we were able to partner with the Canadian Foundation of Healthcare Improvement in Ottawa, and we're scaling those up across Canada, and we're just in the midst of that. That's going to be in 18 primary care groups in the country that are evenly spread among the provinces. And you'll hear about 2 of those this afternoon. They're the CARES model in Simon Fraser, and also from Linda Lee from the Waterloo area. And all these innovations use the similar type of paradigm that I discussed before. They screen for frailty in primary care, people presenting, and then that leads to more detailed assessment, such that they can have tailored care. And the ways that the screening is done as primary care is using the clinical frailty scale, which is through the CARES model, and the 4-meter gait or hand grip strength, which is the C575, which you'll be hearing this afternoon. And because of that screening, then you're able to change care to implement person-centered, evidence-informed frailty interventions and customized care plans using an interprofessional team and community supports. And this is the conceptual model. Basically, what we want to do is take a group of people who are older, use frailty case finding, and stratify them into people that are frail, people that are fit, and the people that are frail, they can go under a much more comprehensive assessment, and that leads to integrated, individualized, patient-centered care. Certainly in the practices, in the innovative practices that's being done, that's improved outcomes, and now the next step will be to scale that much more broadly, which we're currently doing, along with rigorous assessment to be sure that the practice change that it entails is leading to the desired outcomes. So that's an example from Canada. That's local innovation. This next example that I'm going to use about tailored care is from the United Kingdom and the National Health Services. And just I'm an acute care physician, so I can say this, but so hospitals and emergency departments are hostile environments for frail patients. We do terrible things to people that are frail. We do terrible things to everybody, but if you're younger and you can get over it, then we improve care. If you're frail and you come into the emergency department and you spend 24 hours on a gurney, hard gurney, not getting out of bed with the lights on, that's not going to lead to a good outcome. You're going to become delirious. Just being in bed for a couple of days, you lose muscle strength. And recovery when you're frail is much harder. So in the UK, they developed an acute frailty network. And this is a national quality improvement collaborative designed to support acute hospitals in England to deliver evidence-based care for older people living with frailty. They've had 70 hospitals that participate in this. And basically, some of the principles that they used are, again, they implemented frailty screening for people presenting to the emergency department, and I'll show you how they screen for frailty. If you screen positive, then you get a multidisciplinary assessment within 1 or 2 hours of presenting to the emergency department. When has that ever happened to any of our emergency departments? And the multidisciplinary assessment, a lot of times it's led by geriatricians, but there's also nurse-led assessment, and that's a comprehensive geriatric assessment. I'll show you on the next slide what that entails, and that leads to targeted care plans. And the targeted care plans will recognize the determinants of frailty and lead to to address those things, along addressing to a lot of the things. Key staff, both in hospital and those supporting the hospital, and they've tried to strengthen links to services inside and outside the hospital. So this is their screening that they use. If you're over the age of 85, you screen positive. If you're over 65 and you have cognitive impairment, if you're a long-term care resident, if you present with fractures, with osteoporotic fractures, if you have Parkinson's, or you present with recurrent falls, and they also use the clinical frailty scale that I talked about before, which takes 1 to 2 minutes to do. And if you screen positive, then you undergo a rapid assessment, which is within a couple hours of presenting, and that's a multi-dimensional interdisciplinary diagnostic process that looks at physical, mental, psychological, functional status, your social status, and environmental causes why you're frail. And the evidence coming out of this is individual case studies at the hospital levels. But all the hospitals, and if you go to the acute frailty website, you can look at the case reports from the various hospitals. All the hospitals that have reported, they uniformly report reduction in the length of stay of people that are admitted. They report the reduction in the number of long stay patients. They look at that there's an increased avoidance of admissions. There's high satisfaction with care. And importantly, like I tried to say before, is that with healthcare costs, they report reduced costs with better care. So how can we actually argue with that? That's the panacea of what we want to go look at as we go forward. So I think, and we've had discussions in Nova Scotia. There's interest in bringing that model to Nova Scotia, and I think that model could be applicable to other places. Now, if you want to be a cynic, you can say, well, they have many more geriatricians and they have a different practice environment, but we need to get outside of that negative thinking and look at workarounds. So obviously, we absolutely need many more geriatricians in Canada. That's not a question, and we need to work that. We need to work at that. We need to increasingly advocate for that. But we can't wait for the 10 years or the number of years to increase the number of geriatricians. There's workarounds. There's multidisciplinary teams that we can leverage to actually do that work. So I think that's going to be an area of interest going forward. The last place that we can target, or another example, is to look at frailty and in surgical outcomes. So there's an increasing recognition that that if you're frail and have any surgical procedure, you're at higher risk of dying. That's similar than someone of similar age that's not frail that has that same procedure. You're at increased risk of post-operative complications. You're going to spend a lot longer time in the hospital, and there's increasing costs. And there's an increasing number of publications that delineate that, and there's also increasing number of interventions that are starting to be described that try to alleviate that. And the interventions that you can use, so basically it's the same paradigm. You identify frailty, you need to do something with it. Oh, that's me. And I'm almost done. I have 2 more slides. So this applies to all general surgery. It applies to when you're having cardiac surgery. Again, if you're frail and you have a cardiac surgery, you're going to spend a lot longer time in the hospital and you have increased 1-year mortality. So what can you do about that? There's increasing work on prehabilitation. So this is the concept that you implement a preoperative intervention to increase your reserve, to make you much more fitter so you can better withstand the stress of surgery and avoid complications. And the two things that have been studied are nutrition and exercise. And the preliminary evidence that this improves patient satisfaction, it's safe, it's feasible, you can do it, and there's a suggestion that it improves outcomes. There's large randomized control studies that are underway. Dr. McIsaac out of Ottawa is running one funded by Canadian Institutes of Health Research. We funded the pilot work, and that's going on to provide definitive evidence that that's going to work, and also look at the best ways of doing it. But the other important thing is that you can actually embark on shared decision making. You know that if you're going to, and some of this work is being done by Dr. Greg Hirsch in Dalhousie that looks at frailty assessments to inform care decisions. We know that a lot of that if you have advanced stages of frailty, you're not going to do well with cardiac surgery. And you may want to take that risk, but you need to be informed about that the outcome may not be as good as you might think. And using the frailty assessment to inform the shared decision making is an ongoing work. And some of the preliminary evidence shows that it does work. You can use it, and people are satisfied with the decision making process that they've come out of that. And so finally, I'm sorry, I'm a bit over. Frailty prevalence increases with age, importantly, but it is not an inevitable part of aging. If you're frail, it's associated with worsened outcomes. If frailty is assessed, it should lead to more detailed assessment and a tailored care plan, and we can change outcomes by doing that. And to improve outcomes, we need to improve both health and social care. And I'm going to finish off on that. Thank you for the attention.
Thanks, John. Not now. Thanks very much, John. So you can see that was a fairly deep dive in a lot of work that's taken place over the last 7 years from the Canadian Frailty Network, and we'll hear more about it over this next day and a half. I couldn't help but think a little bit during that conversation. Some of you will identify with this. In the post-Second World War years, in the 50s particularly, and in the 50s, 60s, there was a baby boom. And at the time, I recollect, even as a child, being aware of the fact that there was a system-level movement in this country to recognize children. And when I started medical school in 1969, we had pediatric hospitals at that point in time, but we really didn't have what I would call children-friendly care. But it started to happen, and I don't know how the other physicians in the room would see this, but through the 60s and the 70s, we saw change in attitude towards treatment of children, a different therapeutic approach, different management of their medications, their fluid management. And what was really apparent to me as a medical student is that we went through a transition where, mainly because of fussing from parents, keeping children quiet for a whole day while they got progressively bumped in their surgical queue, NPO during that period of time, things changed. And we became children-friendly. And we started having early morning cases where you would not basically starve and deprive these children of food and water for a long period of time. They were done early in the morning. It was easier on the parents. And we just saw a transition, I think, in care for children, recognizing that they're just not small adults. Okay, now flip it. It's almost 2020. Old adults are not just younger people that have gotten old. They need additional and different kinds of care. And that's really true, and we really heard that with frailty. So as a practicing ICU physician, about a quarter to a third of the patients I would look after were over age 65. When John goes to work now, between a third and a half of them are over age 65, and about 20 to 25% of them are over age 80. And he talked about cardiovascular surgery. If you go into a cardiovascular surgical unit now, about half the patients will be over age 65, many over age 80, and they're there for different things than they were ever there before. They used to be there getting coronary bypass. They're not there for that now. They're there for valve surgery. Valve surgery in 80-year-olds is a big deal. It's a really big deal if they're frail. Or let's make it a little more simple. Every day, thousands of people come to the emergency departments of this country. And being fastidious about things like fluid management, one of the early things that we actually often do, besides starting an IV, is we pop in a catheter into the bladder. You probably shouldn't be doing that in particularly older people and particularly frail people. Because, you know, for every 100 catheters you put in one of those people, about 5 or 6 of them are going to get urosepsis, and 1 or 2 of them will end up in his unit with multisystem organ failure. This is one of those kinds of things where it's not therapeutic nihilism. We just need to think differently about our meds, our fluids, our food, and everything we do if we're ever going to get anywhere with elder-friendly care. We don't have elder-friendly care now in virtually any part of this country. There's a few obvious gold nuggets, places where you're a VIP because you have frailty, where you're treated with an extra special type of care plan that avoids harm being done to you from a system that's trying to help you. So go beyond frailty, and let's now start chatting about dementia. And with about 500,000 people with dementia in the country, we can't ignore it. And I think we all a little bit fear it. The last time I couldn't remember something, you know, and you're probably a little bit like this, you wonder, uh-oh, is this the start of where it's going to go for me? We're not as sharp as we were before. We're not as fit as we were before. We will change over time, and we have to learn and accept all that. But there's no question about the fact that frailty has a bedfellow in dementia. They hang together. One of the features of frailty is your cognitive decline. You can, of course, have dementia without frailty, but generally speaking, if you have frailty, you're going to have cognitive decline. And so it's important for us to talk about them both here this morning to get all of that out on the table. And we're being very, very well equipped in doing that by having David Hogan with us today. David is a geriatrician. Ain't many around. By head count, number of people that are specialists in geriatric medicine are only about 300-ish in this whole country. 300 geriatricians for the whole country of 35, 36 million. 1 in Saskatchewan. Now look, a lot of older care is done by lots of different people on the team. I get that for sure, but the fact that we only have 300 geriatricians is clearly not a country that's looking to be responsive to what's coming. And interestingly enough, I was just reading and doing a review for one of the provinces, writing up their healthcare system of late, and there was a manpower section. I couldn't help but go to it and look at who's being trained into medical school students in that province right now. And I was blown away by the fact that there were 25 pediatric residents and 2 geriatric residents in the whole program. And that's not just true for that province. That kind of resonates across the country. Yeah, it's changing and it's improving, but we don't have enough David Hogans. And David left his office to come here today. His staff really did us a big favor, and he's going to fold back into that office tomorrow as if he wasn't even away. He's been a geriatrician now for a long time at University of Calgary, and in fact, he set up geriatric medicine at University of Calgary and made it what it is today. David, when he's not a clinician, does research. He's published at least 300 different papers on older Canadians and older adults. And his clinical interest is particularly cognition, so a good person to help speak to us about dementia. And he's been involved with major landmark Canadian studies in health and aging. They've looked at things like the incidence, the prevalence of dementia, and its impact. He's spent lots of time particularly thinking about the care plans and the practice guidelines that are most relevant for older adults. It's not just what we do for younger adults. It needs to be different. He's developed guidelines in assessment and management of Alzheimer's disease and other dementias. And over the years, he has developed a real interest in what I might call population therapeutics as it relates to dementia and other aspects of aging. Most importantly, he's a colleague and a friend. Please welcome David Hogan.
Thanks. Thank you very much. So, anyway, Heidi, I'd like to thank Elder Darlene McIntosh for her welcome and her greeting. I'd also like to thank you all for your welcome and your greeting. Now, please feel free to stand up and stretch. It's been kind of a long morning, and I'm just going to take a minute or two to tell you how I got here to Prince George. So I flew in from Calgary, and I'm used to bigger jets than the propeller plane that brought me in here. So a little bit nervous, but the fellow sitting beside me was, in fact, he was from Queens. He was coming here to give a talk, probably at University of Northern British Columbia. And he was working on his talk, but when we took off, when they gave the usual spiel about where the emergency exits were, he spent a lot of time looking for these exits, making me a little bit nervous. And then we were flying in, and it's getting bumpy going over the mountains, but he wasn't particularly nervous. I was getting more and more nervous, but he was working on his talk. So just as we're coming into Prince George, it's very bumpy, we're going up and down. I looked over, and he was working on a slide called Final Thoughts. So I was bad, but then he worked on the next slide, The End. But anyway, I'm glad to be here. Okay, we're all set to go. So I don't have any conflicts of interest to declare. My background is as unsullied as Tom's soul and as pure white as that is. But these are the things I want to talk about. And in the brochure that you have, the last one's been cut off. I also want you to start thinking about the information I'm providing could be of some use to you in improving dementia care in Northern British Columbia. So just to start off with, I'm going to talk a bit about what dementia is. I think you all know it, but I just want to make sure we're all on the same wavelength. So dementia is a set of symptoms caused by disorders of the brain. Usually the problems include memory, but other aspects of thinking would be affected, like language skills, your ability to make decisions. And these problems have to be severe enough that they really impact your ability to do everyday activities. Often people with dementia encounter challenges with their mood and their behavior and what they're called responsive behaviors that also have to be dealt with and can be quite challenging. So dementia is not a specific disease. There are many, many conditions that can lead to dementia. The most common in our country would be Alzheimer's disease. But Alzheimer's is a type or a contributor to dementia. It's not equivalent to dementia. And probably the most common cause of dementia that you will encounter are people who have more than one condition affecting their brain, sort of a mixed picture. They might have had, stroke damage, they might have Alzheimer's, or they might have other conditions contributing to their dementia. It's also important to point out that frailty and dementia are linked. John showed the clinical frailty scale, which was developed in the Canadian Study of Health and Aging. And it was based on a tool that we initially had developed in Halifax to target people for geriatric assessment. So an interesting history to it. But if you looked at it, and down in the corner, it showed that there's a correspondence between levels of dementia and your frailty. So people who have a mild dementia would be equivalent to mild frailty. Moderate would be moderate frailty, and severe dementia would be equivalent to severe frailty. So that's correspondence. But there's also a bidirectional relationship between the two. If you develop a dementia, you will develop, unfortunately, frailty as time goes on. But it's also shown that frailty will increase your risk of developing a dementia. And also frailty will increase your likelihood of developing a dementia with smaller burden or load of brain disorders. So people who have frailty will become clinically overtly demented with less changes in the brain of Alzheimer's than people who are not frail. So there's this very important and interesting relationship between the two. So just a little background information. So I'm going to be talking about a report titled Improving the Quality of Life and Care of Persons Living with Dementia and Their Caregivers, which was published in January of this year. It was brought up by a group. I was a member of the group. It was led by Howard Bergman. Sonia Kupka is from British Columbia, and she lives in the Vancouver area. And the rest of us were from across the country. If you're very interested in the report, please download it. That's a link to it. And there'll be a lot more detail than I'll be able to provide in this relatively brief conversation that we're having this morning. Now, the report was commissioned by the Canadian Academy of Health Sciences. This describes who they are. It's a large group of Canadian health scientists who have a number of academic achievements in their past or felt to be creative and provide leadership to academic health care. I can say this because I'm not a member of the Academy. I was just a foot soldier in producing a report. Other descriptions of the group you can see is collaborative group. It's from across Canada. All health disciplines are members. And reports brought out by the Canadian Academy of Health Sciences are available on their website, and I give you the address as well. So what drove the report? Well, in 2017, there was an Act of Parliament in Ottawa to establish a national strategy for Alzheimer's disease and other dementias. It was an act. And the act stated that we would develop and implement a comprehensive national strategy to address all aspects of dementing illnesses. So why a national strategy? Well, it's driven partly because of the number of people living with dementia now and the number of people that will be living with dementia in the near future. As Tom has mentioned a couple of times already, over 500,000 Canadians right now have a dementia. A report in British Columbia from 2016 estimated that there were 62,000 individuals in British Columbia with a dementia. And with the population growth and also the aging of the British Columbia population, the number of people with dementia in British Columbia would be equivalent to the population of Prince George, 70 to 80,000 people. So think of it, city, everyone affected with a dementia of the size of Prince George. So there's more people. And there's also a need to ensure an adequacy and sustainability of the health and social care system to deal with their needs. And it was felt that there was a need for a strong central vision that would provide direction for mobilizing the needed resources and putting into place strategies that will need to deal with this. So the Minister of Health, through the Public Health Agency of Canada, went to the Canadian Academy of Health Sciences and asked them to provide a report. And the report was supposed to be evidence-informed and should be authoritative as possible, looking at the current state of knowledge about dementia and the practice of caring for people who have a dementia. was to look at the strength of that evidence and also emerging best practices in Canada and also around the world. And it was also very clear that this was to inform, but we were not writing the national plan. So remember, to inform is to help, but it would not be the national plan. So out of scope for the report that we did come up with is, again, we were not writing the plan. In fact, it got to the point that we weren't allowed to make recommendations for the plans. We could give musings and key findings, but we could not say, we think you should do this. So don't tell us, they said. Just summarize the data out there. And I should mention that the strategy was released in June of this year, and you can download it, take a look at it. And I, like the rest of us, lived through the last national election, federal campaign. How often did you hear dementia, healthcare, frailty come up? Much less than blackface. And it was very discouraging campaign in my estimation. I'm not throwing stones at anyone in particular, but the tone and the amount of ink spent on dealing with what are really important issues, there was a mismatch. And I think we all deserve better, and we should be expecting better from our leaders. So we were not to write the report. We didn't deal with elements and issues and terrain outside health and social services. For example, how we establish our towns or cities or municipalities. We didn't have time to do a stakeholder consultation, which was a big gap, because we had a very tight time frame, and I'll come back to that in a minute. And we weren't to talk about the disputes between federal and provincial jurisdictions, which never come up in Canada. So this was the expert panel. Dr. Bergman, I want to point out, was the chair of the Department of Family Medicine at McGill. So this report was based very much in primary care. You can see the other members and where we're all from. And that's a picture of most of us in person. Deborah Morgan had to Skype in for that meeting, and you can see her in the background on screen. So I had, and the rest of us, received our letter of invitation to join the group in January of 2018, and the report was submitted in August of 2018. It was done very quickly. We had 3 in-person meetings, March and June. We had one in September after we had submitted the report for the peer review. And it was a blend of quickly looking at the evidence and also based on what we knew about the evidence, emerging ideas and consensus. We would meet as a group and we would talk things through and we'd see what we would agree on. We looked at Canadian international reviews. We commissioned a review of Alzheimer's disease policies in the Organization for Economic Cooperation and Development countries, the wealthier countries, and looked at reports emanating from these countries. We spent a lot of time looking at provincial dementia strategies, and they provided a lot of direction, and we found that we didn't have to reinvent the wheel, because a lot of this work had been done. And at the end of the report, it did go outside to an external peer group who provided input, and there was final tweaking, and then that was it. And the report was translated and published in January of this year. So panel members, we each took responsibility for particular areas. The area that I was responsible for dealt with research, and I'm not going to talk about research today because of limited time. Also, we all collectively helped set the orientation, looked at the evidence, looked at best practices, and also actual writing of various sections of the report. The report wasn't written by someone external to us. We wrote each part of it individually with assigned responsibility. We also requested short papers from experts and researchers to better understand a number of areas, and I bolded the ones I'm going to be talking about later on. One dealt with rural and remote dementia care, and the other one that I'll be talking about dealt with Indigenous populations in Canada and their experience with dementia. But we also looked at ethnic minorities and recent immigrants, young onset dementia, sexual minorities, adults with intellectual or developmental disabilities, technology for dementia, which is a very hot area, a lot of innovation. And we also did an international review of Alzheimer's disease policies in these wealthier countries, the OECD countries. I bolded the areas that I'm going to review. So while we didn't make recommendations, we came up with 44 wink key findings. And I'm going to be reviewing a number of them. In the slides I show all of them in particular areas, but I'm only going to talk about one or two per slide. I just wanted to put them all in because I'm sure some of you will have a particular interest and might want to focus on that particular area. So I'm going to be talking about the importance of engaging persons living with dementia, prevention, awareness, and living well with dementia, improving health and social care for persons living with dementia. And I should point out that all of us are going for that triple aim when we look at health and social services. We want better quality services, we want better outcomes, and we want lower costs. And dealing with education and support for caregivers, and finally building and supporting the health and social care workforce. So in each chapter, we highlighted the challenges. We try to summarize what's been done at a public policy level in our country, and we try to identify things that seem to work and things that look promising. And then we did our key findings summary. Overarching themes that came up through the report is that we have a lot of Canadian experience, and we wanted to build on all the provincial dementia plans which have been in place and are still coming out since the late 1990s. We also looked at now 5 Canadian Dementia Consensus Conferences, which have been held since 1989. The last one was held earlier this month in Quebec City. We also wanted to build on the Canadian experience and research and also the very innovative and interesting approaches which we find across our country. A really important theme was the centrality of engaging persons living with dementia and their caregivers in a very meaningful and respectful manner. They've often been a silent partner in a lot of this work, and they really have to come in and be recognized as full and really the most important members of the team trying to wrestle with this challenging problem. So this just lists the various provincial government plans for dementia strategies and action plans. You can see in British Columbia, you had one in 2012 and kind of a refresh in 2016. Every Canadian province has a dementia strategy or an action plan or is developing one except for one province. And the one that doesn't have is understandable is Prince Edward Island. Which, very small province would have problems, I think, mustering a group to come together to develop it, but also is a much more constrained horizon. I think people have probably a better understanding of what's needed to be done in that province. Now, another overarching theme is the importance of addressing dementia as a societal health and social issue, and also recognizing the complex combination of health and social needs of persons living with dementia. The thing I want to emphasize here is that it's really important that if you look at the third bullet, the assessment, management, and treatment is anchored in team-based primary care and then integrated with other components of the health and social care system. This is not a specialist disease. This is such a common disease, and it often is in the context of other health issues. It has to be based in primary care. And I should mention that's always been the approach taken in Canada, but that differs from many other countries. For example, in Europe, dementia is viewed as a specialist disease, and much like cancer, If it's diagnosed, you're sent off to a specialty clinic, a memory clinic, for example, in the United Kingdom, and they would deal with dementia in isolation from other aspects of your health. So in Canada, dementia is more like diabetes, in that most diabetic care is provided through primary care and not through a specialist. So other overarching themes, so the three listed here, it's important that we have an adequately trained, supported dementia workforce to deal with current and also projected demand. We have to have in research an equitable balance in research investment across biomedical, clinical, health services, social, cultural, and environmental, and population health. And we can't invest solely in one aspect, in one area of research. It's important to search for a cure, but we have to deal with need now. And it's important we have a balance between the two. And then finally, that we should create and seek out and utilize evidence and best practices to implement a national strategy in a coherent and practical way, which I think will be very challenging. You probably gathered with the last federal election, there's not a lot of love being shared between some provinces and the federal government. And I can speak for my home province. It's going to be very difficult for the leadership in Alberta to kind of embrace anything coming from Ottawa in the near future. It has nothing to do with the dementia strategy. It's just the reality of politics, unfortunately. So the first chapter dealt with engaging persons living with dementia. And these are the, some of the key findings we came up with. I'll just focus on the second one here. It is becoming more common to engage persons with dementia in their own care, as well as shaping health services and conducting research. And this approach is essentially unanimously endorsed in all the provincial plans in our country, but also internationally. And it's much more important, it is becoming more and more important to realize that and actually walk the talk and engage people living with dementia in these activities. So in dealing with prevention, awareness, and living well with dementia, I think the most important one is probably the first step. That we believed when we looked at the evidence that there was sufficient research to encourage the adoption of health promotion endeavors that will hopefully decrease the likelihood of developing dementia in the future. It's not commonly known, but in the wealthier countries of the world, for example, in European countries, United States, and Canada, there's evidence that the likelihood of developing dementia is dropping. So there's still going to be more people, unfortunately, suffering from dementia because of the aging of society. But if you took 100 people 65 and over now and compared it to 100 people 65 and over 20 years ago, per 100 people, there are fewer cases of dementia. So it's dropping. And the reasons for that aren't entirely clear. It might be because of better education. It might be because of just better wealth and standards of living. It might be because of better detection of risk factors for dementia in the future, such as high blood pressure or diabetes, and dealing with it earlier and preventing damage to the brain. Not clear, but it's dropping. It's very hopeful. An overall figure has been estimated that about 35% of all cases of dementia in the developed world are due to modifiable risk factors. Education, I mentioned, vascular risk factors are also very important. Do you know what is potentially the greatest one? Hearing loss. Hearing loss is a risk factor for developing dementia. And when you lose hearing, you get isolated. There's also changes in the networks within your brain. And if we could intervene and do something about hearing loss, that might have the single greatest impact on preventing future cases of dementia. This also comes to a point, and I'm not going to talk about research to any great degree, but it's important that we invest in research to truly understand how to bend the curve and decrease the likelihood and the risk of any of us developing dementia in the near future. So both of these, I think, are very important. a massive issue for people living with dementia is trying to deal with the stigma and fear they encounter. People are afraid of dementia. And people view you differently and treat you differently if they know you have a dementia or suspect you have a dementia. Another very promising area is developing dementia-friendly communities. I know this is being done in British Columbia, but it's trying to make our communities friendlier to people suffering from dementia. It's easier for them to live in their communities, and also to feel accepted and appreciated and not isolated. For improving health and social care, person living with dementia, just focus on the second one. Read the first one if you have time and an interest, but you really have to think of dementia as a complex condition, and it requires a complex combination of social and health care. And it's important that the care we provide would be person and family-centered rather than disease-centered, much like frailty, as John said, and that it's based very much on relationships between you and the patient and their family, or client if you prefer that term rather than patient. Here, both I think are equally important, but the focus in delivery of good dementia care has to be primary health care. The things I do as a specialist, or things that John or Tom might do as specialists, I think are important, but they're not core and critical. So we really have to think harder about how best to do that in a primary care center, providing good dementia care. And there are good examples here in Canada, and Linda Lee will be speaking about a very interesting model in Ontario, I think more about the frailty, but it also was developed for dementia, and I'm sure Linda would be more than willing to talk about that. The third point here is an important one. I think we have to consider advanced care planning. It's not a panacea for all the issues we're facing, but particularly with a progressive dementia, it's important to get an indication about who that person wants to make decisions for them, and also a good sense of their values and aspirations and limitations to that care which will be provided. A very thorny issue for us right now is medically assisted death and what to do with this whole question of dementia. Because as you know, the current rules are you have to be corpus mentis, have capacity at the moment to be able to have that option available to you. An advance directive indicating that you'd want it at a certain stage would not be considered sufficient. I think the second point is one I'd like to emphasize here. We have to train family caregivers, but they have to be supported in their caring roles. And we have to also think about their quality of life and how we can promote their resiliency and their ability to deal with the load they are facing would be critical. The third point is another one that's important to keep in mind, that dementia is not only, but is a predominant women's issue. Most people with dementia are women, and most caregivers of people with dementia are women, both formal and informal. For education and support of caregivers, the first point I think I just want to emphasize, this is a role of the NGOs, in particular the Alzheimer's Societies and Caregivers Associations in Canada. They play a very important role in empowering, educating, and supporting caregivers, and also advocating for their needs. And again here, and supporting the health and social care workforce, the first point I just want to emphasize that all provincial strategies, and most international ones, recognize the need for this. That we have to have the workforce in place to be able to deal with the current, but also the growing need in the future. Now, in building, supporting the healthcare workforce, I think the one I'll mention here is E, is that we have to continuously update our guidelines, recommendations for how to provide good dementia care. As I mentioned, the 5th Canadian Consensus Conference on Diagnosis and Treatment of Dementia just occurred in Quebec City. It's going to be really important to translate that these recommendations into something practical for people providing the care to individuals suffering from dementia. Now, I'm going to move on and the time remaining, just talk about two of the Commission reports. If you want copies of the Commission reports, you can get it from that website. And I've listed all of them again, but I'm just going to be talking about rural dementia care, which was written by Deborah Morgan, one of the members of our group who came up with the report, and Indigenous population, which was written by Kristen Jacqueline before she moved to the United States. So rural dementia care. The unique features about rural and remote dementia care is clearly you have low population densities. You have limited transportation options and often longer distances to travel. And you have limited social support. Often family members have moved and no longer live in those communities. And also you would have more limited health and social services available. It appears that key issues in rural and remote areas would be access to a timely diagnosis, support and education for individuals with dementia and their caregivers, and access to education and specialist support for rural healthcare providers. I'll give you an example of very recent research that I think is relevant to these questions. There's a paper that's just been published online in a journal called JAMA Internal Medicine. It's about a telephone, internet-based dementia case managing intervention. It was done in the United States, it was done in California, and in Nebraska and Iowa. There was no face-to-face contact between the case manager and the person with dementia and their caregiver. It was done in large geographic areas. But they had care team navigators who were trained to deal with the immediate needs or issues of the caregiver, and they would be in phone or email contact, and then would go through a checklist to cover off important areas like use of medications or safety of the individual, education needs for the caregiver in particular, and what referrals are being made or should be made, focusing on caregiver well-being, looking at responsive behaviors and how to manage them, and also dealing with advanced care planning. Generally, there was one phone call a month, between the case manager and the dyad, the person living with dementia, and their caregiver. And over a year, the intervention led to significant improvements in the quality of life of the individual with dementia, significant decreases in depression and burden on the part of caregivers, and a decrease in emergency room visits by the person living with dementia. And this is a type of innovation that could be built upon on some activities we have in our country and could be, I think, of particular utility in rural and remote communities. I also just want to mention, before I leave rural and remote, is that there's a lot of work with telehealth and video conferencing. That's a lot of it has been done here in Canada and should be supported. The Alzheimer's Society First Link program is also a good way to connect families and caregivers and people living with dementia with an NGO that can provide a lot of support. There are telehealth and internet-based support groups for people living in rural and remote areas that would be beneficial. Online educational tools and distance learning are also interventions that have been looked at. Strangely enough, for innovations in this area and supporting rural communities and remote communities, a lot of work has come from Australia, which I can understand, but also a lot of work has come from Austria. I thought Austria was like Prince George size, geographically, but apparently a lot of work has been done there as well. Now, what about Indigenous people? One thing is that, much like frailty, dementia is more common in Indigenous communities as compared to non-Indigenous communities. The rates for dementia are about 34% higher if you correct for age and sex in Indigenous communities. And they're increasing at a faster rate than you see in the non-Indigenous population. When dementia does develop, much like frailty, it comes earlier, maybe about 10 years earlier. And strangely, it affects men more than women. Non-Indigenous populations, it's the other way around. Women are more affected than men. The high rates and high numbers are not solely due to an aging population. There are also higher rates of social and health risk factors. Some of them are traditional, things like hypertension and diabetes, and some are not traditional. The stress and strain of colonization and the residential school issue. I should mention that I was very surprised to find out when I was talking to colleagues in Australia, the same thing happened in Australia, almost identical to what occurred in Canada. Indigenous understanding of dementia does emphasize acceptance and inclusion, and that does provide opportunities for community-based caregiving. Culturally grounded and strength-based approaches would be very helpful. In Indigenous communities, there's recognition that dementia might be a natural event or consequence and is part of the circle of life. And it might be more accepting for people with dementia in Indigenous communities as compared to non-Indigenous. Particular issues include the ones listed here: delays in diagnosis and provision of services. It's partly driven by location, but also partly driven by perception that mainstream health and social services are culturally unsafe for older Indigenous people. Informal caregiving is the most common approach in Indigenous communities to dementia, and the preference is to keep older Indigenous people in their own communities. Long-term care facilities are often viewed as the last resort, and part of that is driven by the traumatic institutional experiences with residential schools, it's felt. There are training needs for informal caregivers, but also for formal caregivers in providing dementia care and a culturally safe and sensitive dementia care approach. So that's really all I would have to say. I thank you for your attention. And as my grandfather used to say, I hope in the future your roof doesn't fall in on you, and also you don't fall out with your friends. Thanks very much.
Thanks. I think you'd have to agree with me, two outstanding presentations to get us started, an enormous amount for us to think about from what we've heard. I'd never really appreciated, David, the importance of the hearing part that you've mentioned. And also, you raised a very thorny issue. It's very current right now in the media and some recent things that we've seen in the press. Medical assistance in dying and dementia, that's an extremely complex issue. We absolutely don't have that sorted out, and I'm sure that we could easily understand how deep the arguments go on both sides of that. We need to have some real sensible ground in the middle, I might suggest. The other thing you said is you commented that in the election, I mean, we don't want to get off on the election, I'm sure. But you're quite right, it really didn't come up. I actually, kind of listened for it. Because what many of you don't know, Joyce and John and many of us, about most of the Canadian Frailty Network board decided that we were going to get political about 3 or 4 months ago. And we swooped into Ottawa to meet some MPs and senators. They were very gracious. It was a very interesting experience for some of us who never had that experience before. We talked to over 20 people from political backgrounds, again, MPs and senators. We got a great reception. There was some confusion in their understanding, but actually I came away from the feeling that the politicians actually do understand that we have an issue here. And when you actually got their attention and discussed it, some of them actually had quite a lot of interesting thought, and you could tell that they would be highly motivated to do things about it. But you could also tell during that time, and that was October, right? May. Right. You could also tell then, that's right, it was just after the SNC-Lavalin thing went crazy, right? So they were really preoccupied, and so in many respects, while we went there to try to promote the agenda for frailty and dementia and a new time for Canada, it regrettably, despite our best efforts, didn't end up on the docket for consideration. But we certainly have a number of receptors primed, and we are going back and hopefully get their attention. So you get a break now. You've been very gracious. We're actually a little ahead of time. Want you to convene if you wait. We'll get everybody back in here at 11. And the moderators that we've asked to help us with the individual tables, when you come back after the break, if we just assemble here, we'll do a last minute or two adjustment, and away we go. So enjoy your break, everyone. Thanks very much.
Singing to myself.